Hello students, welcome to this quick revision in head and neck. Head and neck itself is very important. To concise it and give it, it's a very big challenge and we have done it for you. Okay, so all the high yield topics with the key points is going to be delivered in this. Give your attention. Muscles of face is a very high yield topic. The muscles over the face, they differ from the muscles in the rest of the body. Can you tell me how? Yes, all of them are subcutaneous beneath the skin. They are all derived from the mesoderm of second pharyngeal arch. And what is the nerve of the second pharyngeal arch? The facial nerve innervates all of them. They are considered to be remnant of panniculus carnosus. Of the muscles of face, there are many minute muscles, right? The two major muscles that you should definitely know is Orbicularis oculi and beneath the muscles of the upper lip, okay, on a deeper plane, we have the Buccinator. These two are frequently asked short note for your theory examination and spotters. So you should be like thorough with it, and we have talked about it in detail in the comprehensive chapter. Okay, so here in our quick revision, we'll be just going through the key points expected from you in your answer. Right. So the Orbicularis oculi, can you tell me what is its action? It helps to close the eyes. Okay. And this is the frontal belly of occipitofrontalis, the frontalis muscle, which is responsible for producing the transverse wrinkles over the forehead. Okay. So this is the Buccinator muscle. It arises from, okay, it has upper fibers arising from the maxilla opposite the molar tooth. The lower fibers coming from the mandible opposite the molar tooth. And the middle fibers, they come from the pterygomandibular raphe. And this is something special, okay? I told you all the muscles of the face, they are beneath the skin. And this Buccinator is going to be covered by a fascia, the buccopharyngeal fascia. So buccal refers to cheek, right? So we have the buccal pad of fat and then the buccopharyngeal fascia covering the Buccinator muscle. And what is the structure piercing the Buccinator, anyone? Come on. Yes, the parotid duct pierces the Buccinator. One more, the buccal branch of mandibular nerve. There are two buccal nerves, yes. The buccal branch of facial nerve, it supplies the Buccinator, right? Buccal branch of facial nerve. The lower buccal branch of facial nerve is motor to the Buccinator. The buccal branch of mandibular nerve, it pierces the Buccinator to supply the skin over the cheek and also the mucous membrane of the vestibule, and it is entirely sensory. Okay, and the parotid duct, it pierces the Buccinator to open into the vestibule opposite the second molar tooth. What is the action of Buccinator? Vestibule. It compresses the vestibule and it tries to expel anything inside the vestibule. It prevents food accumulation within the vestibule and also expels the air. It's also called the whistler's muscle, trumpeter's muscle, Buccinator. The key points related to Buccinator. Coming to the innervation of the facial muscles, it's by the facial nerve, the seventh cranial nerve. So the seventh cranial nerve, it exits through the stylomastoid foramen. It gives this posterior auricular branch. The posterior auricular branch of the facial nerve, it supplies the occipital belly of occipitofrontalis. The auricular muscles, they are, you can see here, the auricularis superior, auricularis posterior. And then it enters the parotid gland where it's going to divide into 5 main branches. This pattern of radiating branches, what is it called? Pes anserinus. It looks like the goose foot, right? Let us identify these branches because they can be asked in an image-based question in your spotter and also in MCQ. So this one is the temporal branch of facial nerve. Below that, is the zygomatic branch. Okay, you see the parotid duct here, yeah, piercing the buccinator. Above that is the upper buccal nerve. And below that is the lower buccal branch. And running along the mandible, that's the marginal mandibular branch of facial nerve. Towards the neck, this is the cervical branch of facial nerve. The temporal branch, as you see here, it supplies auricularis superior, auricularis anterior, right? The frontal belly of occipital frontalis and upper part of orbicularis oculi. The zygomatic branch, it supplies the lower part of orbicularis oculi. The upper buccal nerve, right? It supplies the muscles of upper lip. The lower buccal branch is the one that supplies the buccinator muscle. Okay. The marginal mandibular nerve that supplies the muscles of lower lip. And the cervical branch of the facial nerve, it supplies the subcutaneous muscle of the neck. What is it? Platysma. When there is an injury to the facial nerve after it exits from the stylomastoid foramen, what will it lead to? Paralysis of the muscles innervated by the facial nerve, which we call it as Bell's palsy. Okay, we see that this exit of the facial nerve from the stylomastoid foramen is a bit superficial. So any trauma to that part of the nerve, okay, can trigger facial nerve injury. So what are the features of facial nerve injury? Yes. So if this is the right side of the face and left side of the face, which side is affected? Okay. The right side in this image. I'll tell you. So on the right side, can you appreciate? Okay, here the patient is not able to close her eyes. Not able to close. What is the muscle responsible for closing the eyes? Orbicularis oculi. What are the three parts of orbicularis oculi? The orbital part, the palpebral part, and the lacrimal part. Okay, and then obliteration. So can you appreciate the nasolabial furrow there? Obliteration of the nasolabial furrow due to paralysis of the muscles of upper lip and lower lip. The buccinator, right? The buccinator is gone. So what happens? The food accumulates. Food accumulates within the vestibule. That gives it a puffed up appearance. Okay. Food accumulation within the vestibule of the mouth due to paralysis of buccinator muscle, which is responsible for keeping the vestibule empty by compression. And then can you appreciate the drooping of angle of mouth, right? The patient is not able to close her lips, right? Close the mouth. And in that case, drooling of saliva will be seen. The muscle responsible for pursing the lids for closure of mouth is Orbicularis oris. So that is not possible. Also, though it's not evident in this case, absent of transverse wrinkles over the forehead. These are the features of facial nerve palsy, Bell's palsy. Absent transverse wrinkles, not able to close the eyes, obliteration of nasolabial furrow, drooping of the angle of mouth on the affected side, drooling of saliva, and puffed up cheek. Okay? Now, we have two types of facial nerve palsy, upper motor neuron and lower motor neuron type of facial palsy, of which the lower motor neuron type, that's injury to the facial nerve after its exit from stylomastoid foramen, only that we call it as Bell's palsy. There's a major difference between upper motor neuron and lower motor neuron type of facial palsy. What do you mean by upper motor neuron? The neurons which are seen in the cerebral cortex. We have a right and left cerebral cortex. The right cerebral cortex has control over left side of the body, isn't it? So an upper motor neuron lesion, please remember the contralateral side is affected. Okay, and lower motor neuron, those in the spinal cord, yeah. So here the ipsilateral, ipsilateral. The other neurons in the brainstem spinal cord, we call them as lower motor neuron. So injury to that will produce a lower motor neuron type of facial palsy on the same side, right? Okay, and then another important thing, please remember, in upper motor neuron lesion, the upper face is paired. Okay, so can you appreciate here? This part of the face only is involved in upper motor neuron. Yeah, the upper face is paired because the upper face is controlled by both the cortex, bicortically represented, bicortical representation. Okay, so in upper motor neuron lesion, contralateral lower face. So the transverse wrinkles and the closure of the eyes, those are not affected. Lower motor neuron lesion, ipsilateral face, ipsilateral entire face. Got it? Okay, now we are moving on to another very important topic, functional columns of cranial nerves. Okay, it is like some of you might find it difficult, but I'm here to simplify it to the basics. Okay, if you understand the basics, you can just like that answer it. Very easy, we'll do it. So here, this is the brainstem. What are the parts of the brainstem? This is the pons. This is the cerebral peduncle of the midbrain. Above the pons, it's the midbrain, and below the pons, that is the medulla. Okay, so in the brainstem, we are going to see the exit of the cranial nerves. The midbrain is related to the cranial nerves 3 and 4. The fourth cranial nerve is the only one that has a dorsal exit. We can see that all the cranial nerves, they emerge from the ventral surface of the brainstem, whereas the fourth cranial nerve that comes from the dorsal aspect to the ventral aspect. Okay, it's the only cranial nerve that emerges from the dorsal aspect of the brainstem, from the midbrain, right? And the pons, what you see here, is the thickest of all the cranial nerves, the trigeminal nerve. At the junction of the pons with the medulla, this is the 6th abducent nerve, the 7th nerve, and this is the 8th cranial nerve. Okay, and the medulla is related to cranial nerve 9, 10, 11, 12. This is the pyramid. It's produced by the underlying corticospinal fibers. The bulge that you see next to it, that's the olive. It's produced by the inferior olivary nucleus. Behind the olive, can you see a sulcus here? The posterolateral sulcus of medulla, related to the emergence of 9th, 10th and 11th cranial nerve. From the anterolateral sulcus between the pyramid and the olive, what you see here, this is the emergence of the 12th cranial nerve. Okay, and also remember, this juncture is called the CP angle. Cerebellopontine angle, this is the cerebellum. Okay, related to the CP angle, we have the 7th, 8th and the 9th cranial nerves. Any lesion here, okay, it can affect all these 3 nerves, 7th nerve, 8th nerve and 9th nerve, they are closer together. Okay, so yes, the exit of the cranial nerves from the brainstem, it has been asked as an image-based question in your competitive examination. Okay, so they won't ask you to identify that. Identification is expected. Other questions will be put on it. Yes, once they exit through the brainstem, these cranial nerves, they pass through the posterior cranial fossa. All the cranial nerves, 3 to 12, what we saw now, coming from the brainstem, they pass through the posterior cranial fossa. This is the region of posterior cranial fossa. Okay, and they exit the cranial cavity through some foramen. We are going to identify the foramen related to these cranial nerves. Now, here, this one here, that's the hypoglossal canal. So, as the name suggests, what is the cranial nerve exiting through that? The 12th nerve. This here is the jugular foramen. The jugular foramen the intermediate compartment of the jugular foramen that transmits the cranial nerve 9, 10 and 11. Okay, above that, this is the petrous part of the temporal bone, the pyramidal shape that you see here. It has the internal acoustic meatus. The internal acoustic meatus, it transmits the 7th and 8th cranial nerve. Okay, and then here, this one, the foramen ovale. The foramen ovale that we see in the middle cranial fossa, that transmits the mandibular division of the trigeminal nerve, right? The trigeminal nerve, as the name suggests, tri. What are the 3 divisions of the trigeminal nerve? Ophthalmic nerve, maxillary nerve and mandibular nerve. Foramen ovale transmits the mandibular division of trigeminal nerve. This is the foramen rotundum. The foramen rotundum, it transmits the maxillary division of trigeminal nerve, the 2nd division. Can you make out the superior orbital fissure here? The superior orbital fissure, it transmits the 3rd nerve, oculomotor nerve, the trochlear nerve, the 6th nerve, and which division of the trigeminal nerve is left out? The ophthalmic division of the trigeminal nerve. Again, this is another important question, okay? So, in your osteology viva, these foramen can be probed and they'll ask you what are the structures passing through. In your competitive examination, they've asked repeatedly, okay? It's a very important image-based question. So, here we'll just identify the foramen. Here, hope you can make out the hypoglossal canal. This is the jugular foramen. The internal acoustic meatus in the petrous part of the temporal bone. So, this is the petrous part of the temporal bone that lodges the inner ear and the middle ear. Okay. Here, this is foramen spinosum. The foramen spinosum transmits the middle meningeal artery and the nervus spinosum. At the end, we'll be revising, okay, all the foramen and the other structures passing through. Now, I'm just limiting it to the cranial nerves. This is again the foramen ovale. Yes, the foramen ovale. And just anterior to it, this is the foramen rotundum. Okay. So, this is the optic canal that transmits the optic nerve. This is the superior orbital fissure. So again, this image also they've asked repeatedly in the competitive examination. Now you see the cranial nerves in the cranial cavity. Cranial cavity. Okay, let's identify. So here again, these are the rootlets of the hypoglossal nerve. In the jugular foramen 9th, 10th and 11th, over the internal acoustic meatus, 7th and 8th cranial nerve. This is the 6th cranial nerve. Whenever the intracranial pressure increases, this one gets commonly affected. Okay, the largest of the cranial nerve, this one, the 5th, and here the 4th. The 4th cranial nerve is the thinnest one, and this one is the oculomotor. This is the optic nerve. Here you're seeing the olfactory bulb. Is that fine? So definitely you should be able to identify the cranial nerves in the cranial cavity. Okay. So this is a picture of the spinal cord cross section. You can make out the anterior gray horn and posterior gray horn. Which one is motor, which one is sensory? The anterior gray horn is motor and the posterior gray horn is sensory, isn't it? Okay. Similarly, this is spinal cord. If we go up in the medulla, in the pons and the midbrain, in the embryogenic period, okay, we have the motor nuclei and the sensory nuclei. They are arranged as functional columns from which the cranial nerves emerge. Okay. So, this here will be the motor, or what is its other name? Efferent column. And this one here is the sensory or the afferent column. Now, Dividing these two, in between, we have the sulcus limitans. Okay, this is the midline. Yes, now you can see. Okay, so as we go down, what will happen? You can see the sensory column going posteriorly, isn't it? Okay, so we have the efferent and the afferent column. Now let us label. Come on. So this is going to be the general visceral efferent. Please don't get irritated with these terminologies. Once you understand their simple explanation, it's going to make things drastically easy. Okay, just stay with me for next 2 to 3 minutes. So this is general visceral efferent. This will be special visceral efferent column, general somatic efferent. And then comes here general visceral afferent, special visceral afferent, general somatic afferent, special somatic afferent. Okay, now explaining one terminology is going to make everything simple. I just want you to make this table where you can write the functional column, the meaning that I'm going to tell you now, you can enter in the middle, and the cranial nerves which come under those columns. Is this one table will help you to give a quick revision just before your exams. You will have everything at the tip of your fingers. It's not just memorizing, but understanding and remembering. Come on, let's start. General somatic efferent. So, you know, in the embryo, the trilaminar germ disc, what are the 3 germ layers? Ectoderm, mesoderm, and endoderm. What are the 3 subdivisions of the mesoderm? Yes, we have the paraxial mesoderm. So this is the ectoderm. This one will be the endoderm, right? So closer to the midline, what you see here will be the paraxial mesoderm, right? And next to that will be the intermediate mesoderm. And then we have the lateral plate mesoderm. This paraxial mesoderm is going to give rise to the somites. Somites are easy to identify in the embryo. They appear as cubical segments, can you see, on either side of the midline. So these somites in the region of the head and neck, they give rise to muscles of eyeball and muscles of tongue. The cranial nerves which are going to supply the muscles of the head and neck derived from the somites, they come under this column. Okay, so under general somatic efferent, we have the 3rd nerve innervating, yeah, the muscles of the eyeball innervated by 3rd, 4th and 6th. The muscles of the tongue are innervated by the 12th hypoglossal nerve. So 3, 4, 6 and the 12th nerve. They all come under general somatic efferent. Okay, I'll take you back to this picture. Where did we see general somatic efferent? Here is the midline. This is general somatic efferent. So 3, 4, 6 and 12. You can see those cranial nerves emerging on either side of the midline. Okay? Yes. Special visceral efferent. Special visceral efferent means, okay, these are the pharyngeal arches. The mesoderm of the pharyngeal arches will give rise to the muscles of head and neck. And each pharyngeal arch will have a cranial nerve. So the special visceral efferent refers to those cranial nerves which are going to innervate the muscles derived from the pharyngeal arches. So the nerve of the first pharyngeal arch, yes, 1st, 2nd, 3rd, 4th and 6th. I'll give you a mnemonic to remember. My face got very red. Yes, come on. M, the nerve of the first pharyngeal arches, mandibular nerve. The nerve of the second pharyngeal arch, we saw, right? Facial nerve. 3rd arch, glossopharyngeal nerve, the 9th nerve. And 4th arch, vagus nerve, along with the cranial part of the accessory nerve, also the external laryngeal branch of vagus nerve. And 6th arch, It's the recurrent laryngeal nerve, a branch of vagus. Okay. So mandibular nerve, can you list out what are the muscles innervated by mandibular nerve? The 4 muscles of mastication. Masseter, temporalis, medial pterygoid, lateral pterygoid. 2 tensors, what are they? Tensor tympani, tensor belli palatini, anterior belly of digastric and mylohyoid. I'll be repeating it again, okay? So please remember the 4 muscles of mastication, the 2 tensors, tensor tympani, tensor belli palatini, and over the suprahyoid part, we have the anterior belly of digastric and mylohyoid. Facial nerve, the muscles of the face, the muscle within the ear, stapedius, okay, and the stylohyoid posterior belly of digastric. Glossopharyngeal nerve will innervate stylopharyngeus. External laryngeal nerve, cricothyroid. And the cranial part of the accessory through the inner vagus, it will innervate the muscles of soft palate, pharynx. Recurrent laryngeal nerve will innervate the muscles of larynx except cricothyroid. Okay, so this is very important. Lot of MCQs in this area. Which is the nerve of the third arch? What is the muscle supplied by the nerve of the second arch? Okay, everything you should be able to tell. I'll add on to it. There's one more that is expected out of you to know. These, the third, fourth and sixth, the 9th, 10th and the 11th cranial nerve. Okay, these special visceral efferent fibers for the 9th, 10th and the 11th cranial nerve, they come from a nucleus called nucleus ambiguus. Which part of the brainstem was the 9, 10, 11 cranial nerve related to? Medulla. So we have the nucleus ambiguus in the medulla. What are the cranial nerves under special visceral efferent column? The mandibular division of trigeminal nerve, the facial nerve, the glossopharyngeal nerve, the vagus nerve, the accessory nerve, cranial part of accessory nerve. Okay? Coming to general visceral efferent, that one term you have to remember for general visceral efferent is parasympathetic. This by all means you have to memorize, okay? What are the nerves under it? 3, 7, 9, 10. It should be at the tip of your finger. The third nerve, the 7th nerve, the 9th nerve and the 10th nerve. Okay. Third nerve, the parasympathetic nucleus is Edinger-Westphal nucleus. A fancy name, right? Yes, please remember the Edinger-Westphal nucleus. Again, it's there in the midbrain. Superior colliculus level. The preganglionic parasympathetic fibers, they are going to synapse in the ciliary ganglia in the orbit, and they come out as the short ciliary nerves that innervate the ciliaris muscle and the sphincter pupillae. Okay. And coming to the 7th nerve, it has the lacrimatory nucleus in the pons, and those fibers will synapse in the pterygopalatine ganglia, and the postganglionic parasympathetic fibers coming out from it, they innervate the lacrimal gland. Okay. Again, we have the superior salivatory nucleus from which the fibers will go along the facial nerve. They will synapse in the submandibular ganglia to innervate the submandibular and sublingual salivary gland. Okay. And 9th nerve, through the inferior salivatory nucleus, the fibers of which synapse over the otic ganglia, they finally reach the parotid gland, right? And vagus, you know, we have the motor nucleus of vagus or the dorsal nucleus of vagus. They innervate the parasympathetic fibers, they reach the lung, heart and GIT. The ganglia is situated close to the viscera. This table is again important. The name of the cranial nerves, the nucleus, the ganglia and the target. Okay, lot of MCQs can be framed around this topic, highly important. General visceral afferent, just remember the carotid, body and carotid sinus. Okay, and what are the cranial nerve innervating this? The 9th nerve and the 10th nerve. The nucleus related to this column will be nucleus tractus solitarius. Okay, and then we have the special visceral afferent. Okay, that was general visceral afferent. This is special visceral afferent. One word that you should remember here is taste sensation from the tongue. The taste sensation from the posterior most part of the tongue is carried by vagus nerve from the posterior 1/3 and the circumvallate papillae, glossopharyngeal nerve. Taste sensation from the anterior 2/3 of the tongue from the fungiform from the foliate papillae is carried by chorda tympani branch of facial nerve. So these three nerves, the 7th, 9th and 10th, they come under special visceral afferent column, and again it's the nucleus tractus solitarius from which these fibers, general somatic afferent, especially, okay, the sensation from the face is carried by the trigeminal nerve, the ophthalmic, the maxillary and the mandibular division of the trigeminal nerve. Also from the concha of the ear, okay, is innervated by the 10th nerve. The 7th nerve will not have any cutaneous branch, but it will have some indirect communication with this branch of the vagus supplying the concha. And also the 9th nerve. All this 5, 7, 9, 10 will come under general somatic afferent column. And the nucleus for the trigeminal nerve will be the spinal nucleus of the trigeminal nerve, the chief sensory nucleus and the mesencephalic nucleus. The spinal nucleus receives pain and temperature from the face. The chief sensory nucleus receives touch and pressure from the face. The mesencephalic nucleus, proprioception from the mandible, temporomandibular joint and from the extraocular muscles. Okay. Special somatic afferent related to vision and hearing, the optic nerve and the vestibulocochlear nerve. Okay. So did you try to fill this column? The middle part and the last one filled. So did you realize the 9 and 10, other than the first and the last, okay, see, they're related to all other columns. Okay, so yes, we'll be discussing it. And this one is enough before your exams to summarize the entire thing we have discussed over the last 10 or 15 minutes. Come on. Yes, you can tell me. This is the general somatic efferent column. Muscles of the eyeball, 3, 4 and 6, and the muscles of the tongue, hypoglossal nerve. This is the special visceral efferent column. Can you see the pharyngeal arches here? Nerve of the first arch, second arch, the third arch, fourth and sixth arch. And here, general visceral efferent, the parasympathetic glands of the head and neck related to 3, 7, 9, 10. This you have to memorize, keep it at the tip of your fingers. And this is general visceral afferent, innervation of carotid body and carotid sinus, special visceral afferent, taste sensation from the tongue, 7, 9 and 10. This general somatic afferent, remember 5, 7, 9, 10. Easy? Yes. It is a very high yield topic. Once if you have understood, you need not memorize. It will be already there in your grey matter. Yes. And whatever way the question is put, definitely you will be able to answer. Come on. Okay. So I'll read it out for you. 55-year-old Mr. Kaushik, a known diabetic hypertensive, presented to medicine OPD with complaints of inability to close his mouth properly for past 3 days. Physical examination revealed facial asymmetry, dribbling of saliva, diagnosed with facial palsy. Which of the following glands is not innervated by facial nerve? So we know that the facial nerve innervates the facial muscles responsible for facial asymmetry. But they've asked which of the following gland is not innervated by facial nerve? Okay, we saw right, general visceral efferent. Facial gland innervates the lacrimal gland, lacrimatory nucleus. It also innervates the submandibular and sublingual gland. Parotid gland is innervated by Glossopharyngeal nerve. Now we are going on to a very important topic. Like it can be asked in your theory, MCQ, and they keep asking it every year in the competitive exams. Okay, a very important topic. So if you know the key points, the concepts in this topic, you can boldly or more confidently face your exam. All about facial nerve. So the functional columns of the facial nerve, yes, under special visceral efferent, we have the motor nucleus of facial nerve. It is a nerve of second pharyngeal arch. Can I teach you a very easy clue to remember the muscles innervated by facial nerve? Yes, you write it with me. The facial nerve, it innervates the muscles of scalp. What are they? Occipitofrontalis. Right? The muscles of auricle, what were they? We saw it, right? Auricularis anterior, auricularis superior, auricularis posterior. It innervates the facial muscles, the subcutaneous muscles of the face, right? And then the subcutaneous muscle of the neck, platysma. Fifth one, the muscle within the ear. Yes, come on, tell me. Stapedius. Then we have the SPB muscle. I prefer to call it as SPB muscle, okay? The stylohyoid and the posterior belly of digastric. Right? So, I don't know whether you understood it. 7 groups of muscles are innervated by the 7th cranial nerve. The muscles of the scalp, muscle of the auricle, the subcutaneous muscle of the face, muscle of the neck within the ear, SPB, stylohyoid and posterior belly of digastric, right? Okay, that's the motor nucleus of the facial nerve. The lacrimatory nucleus of facial nerve under the general visceral efferent column, we saw it innervating the lacrimal gland, isn't it? The superior salivatory nucleus, yes, again under the general visceral efferent column innervating the submandibular and sublingual salivary gland. Yeah, and the nucleus tractus solitarius. Yes, what was it? Taste sensation. From which part of the tongue? Anterior 2/3 through the chorda tympani branch of facial nerve, and the spinal nucleus of trigeminal nerve through its communication with the 10th nerve, the concha. Yes. So that's all about the facial nerve. This is general somatic afferent. This is your special visceral afferent column. Fine? Okay. So it's not only the muscles of face, it innervates the glands also, lacrimal gland, submandibular gland and the sublingual salivary gland as well as taste sensation. So we saw the, yes, can you tell me where is the facial nerve here? This is pons, this is medulla, this is our facial nerve. So you can see it exiting from the brainstem at the pontomedullary junction. It will pass through the posterior cranial fossa. And where is it going to enter? Come on. This is the internal acoustic meatus. The bottom of that internal acoustic meatus is again divided into 4 quadrants. It will pass through the antero-superior quadrant of the internal acoustic meatus. And what is there? What is the internal acoustic meatus leading to? This I told you is called the petrous part of the temporal bone. What lies within it? The inner ear and the middle ear. So as soon as it enters the internal acoustic meatus, it will be related to the inner ear. But before that, I want to mention you something interesting happening within the pons. I will show you 2 nucleus here. This is the nucleus of the abducent nerve. This is the nucleus of the motor nucleus of the 7th nerve. You can see some of the fibers of the 7th nerve winding around the abducent nucleus, isn't it? Okay, so this winding around, it produces a bulge in the floor of 4th ventricle. which is given a special term called the facial colliculus. Okay? So once they've asked it in the question, injury to the pointed area, what will happen? So what lies underneath the facial colliculus? Two components. One is the abducent nerve, the sixth nerve nucleus. And winding around it is the fibers, the motor fibers of seventh nerve. Since the motor fibers of the seventh nerve are more peripheral, outer, right, that will be the first one to get injured. Okay, so this has been asked previously in your competitive examinations. Okay, and in embryo we'll be learning like why is this occurring. It's due to a phenomenon called neurobiotaxis. It will be explained detailedly in your embryology chapter. Okay, coming back again to the course of the facial nerve, we saw it's entering the inner ear through the anterosuperior quadrant of internal acoustic meatus. So as soon as it comes in, you can see it over the above the vestibule. The facial nerve, it runs above the vestibule of inner ear. And then it reaches the middle ear. In the middle ear, it will be related to two important areas. You can see this is the oblique course, the oblique course of the facial nerve over the medial wall, right? After that, it enters the posterior wall, where it runs more vertically. Can you appreciate that? Vertical bony canal in the posterior wall. And then it's going to exit through the stylomastoid foramen. Okay. Now, while it is within the ear itself, it is going to give rise to few branches. Above the vestibule, this part that we see here is the geniculate ganglia. Okay. This geniculate ganglia will have neurons which are going to receive the taste sensation from the palatine glands through the lesser petrosal nerve. Remember that. And then remember the very first branch of facial nerve, it comes from the geniculate ganglia. It's called the greater petrosal nerve. Do you remember to which secretomotor pathway it is related? Yes, lacrimatory pathway. Very good. Okay, so that's the very first branch. And then we can see the next branch, nerve to stapedius, that supplies the stapedius muscle. And just few millimeters before its exit from the stylomastoid foramen, it will give this special branch, chorda tympani. Why do you think it's called chorda tympani? It's going to course along the tympanic membrane. That's why it's called chorda tympani. And this chorda tympani branch of facial nerve, something different happens. Okay, it joins the lingual nerve. What is this lingual nerve coming from? It's a branch of the mandibular nerve in the infratemporal fossa. It hands over two of its functions to the lingual nerve. The taste sensation from the anterior two-thirds of the tongue, and it carries the preganglionic secretomotor fibers for the submandibular and sublingual salivary gland. So injury to the chorda tympani nerve, patient will not be able to appreciate taste sensation in the anterior two-thirds of the tongue, nor there will be saliva secretion from the submandibular or the sublingual salivary gland. Okay, but it's handing over these functions to the lingual nerve. The three branches within the middle ear, yes, yeah, the greater petrosal nerve, nerve to stapedius, and chorda tympani. Please remember its relation to the inner ear and the medial wall and posterior wall of middle ear. And then we have seen, right, it exits through the stylomastoid foramen, the posterior auricular branch, and here it will give to the nerve to stylohyoid and posterior belly. And here we have seen the branching pattern, pes anserinus pattern of the facial nerve. Okay, the temporal branch, zygomatic. Above the parotid duct, it's going to be the upper buccal, lower buccal innervating the buccinator. This is the marginal mandibular, and this one is the cervical branch of the facial nerve, right? Pes answeriness pattern. And remember, it is going to enter the parotid gland. So within the parotid gland, we have the facial nerve, retromandibular vein, and external carotid artery, of which the facial nerve is the most superficial. So any surgery, anything you want to do in the parotid gland, make sure you're well above the plane of the facial nerve and its branches, so that you don't injure the facial nerve and the patient doesn't go for facial asymmetry. Yes. So here, this is the right face, left side face. Can you tell me which side the facial nerve is injured, right or left? So here the patient is not able to close the eyes. You can appreciate the drooping, isn't it? And a puffed up cheek with obliteration of the nose. So here you can make out the nasolabial furrow. Here it's obliterated. It's a left side lower motor neuron facial palsy. Agree? Come on. Okay. And what is this? So in this image, you see Bell's palsy. And here in the concha, you get to see vesicles. Can you tell me the syndrome related here? Very good. It's called the Ramsay-Hunt syndrome. Okay. So we saw the functional columns, everything, branches of facial nerve, right? We saw the motor branches. We saw the parasympathetic branches. But did I mention any sensory branch? No, the facial nerve doesn't have any sensory branch, but it communicates with the Arnold's nerve or the Alderman's nerve branch of vagus that supplies the concha of the ear. So in patients recovering with Bell's palsy, they presented with lesion over the concha. And then only they realized that there's some communication between this Alderman's nerve and the facial nerve while it's passing through the middle ear. Okay. And then they named it as Ramsay-Hunt syndrome. Fine. Okay. We saw that facial nerve is needed for tear production. So injury to which branch of facial nerve? No tears. Greater petrosal nerve. Okay. Lacrimatory pathway. And then hyperacusis, intolerance to normal sound or even sound that's whispered into the ear. Loss of stapedial reflex in the patient. Which is the nerve injured? Nerve 2, stapedius. And loss of taste from the anterior 2/3 of the tongue. You can smell that it is an orange, but if you try to eat it, it doesn't taste like an orange at all. Absence of taste sensation from the anterior 2/3 of the tongue. The nerve that is injured is chorda tympani nerve. Right? We saw that the chorda tympani also carries the preganglionic secretomotor fibers for the submandibular and sublingual salivary gland, isn't it? So, injury to that, again, no saliva, so that leads to a dry tongue, isn't it? Oral cavity. What is this crocodile tear syndrome or the Bogorad syndrome? Okay. So here, the nerve that is responsible for tear production is greater petrosal nerve. And nerve responsible for salivation is chorda tympani nerve. Okay. So when there's an injury to the proximal to the geniculate ganglia during regeneration phase, if there's a mismatching, if these secretomotor fibers, they go and reach the lacrimal gland or vice versa, then what can happen during salivation? There can be tear production. Okay. Imagine eating a curd rice with a lot of tears running in your eye. Yes, even a food that is kept in front of you while you eat it, the salivation. At the same time, tears running down the eye due to injury of the facial nerve proximal to the geniculate ganglia. It's called the Bogorad syndrome or the crocodile tear syndrome. So facial nerve, it's not just muscles of face. There are so many things to add to it. Just now we saw when the injury is proximal to the geniculate ganglia. Injury is proximal to the geniculate ganglia, crocodile tear syndrome. And injury to the chorda tympani branch, no taste sensation, no salivation, right? Injury to the greater petrosal nerve, again no tears. And nerve to stapedius is injured, yes, hyperacusis. Please remember in the cerebellopontine angle, we saw that the 7th nerve is closely related to the 8th nerve, right? So any tumor of any injury to the 7th nerve, the nearby 8th nerve also can be affected, leading to, yes, postural imbalance, giddiness, all that. And we saw that pons, remember? Yeah. So any syndrome in the pons involving the crus cerebri part, the corticospinal fibers, and the 7th nerve. That can also, you can see involvement of the 7th nerve and the 6th nerve in syndromes related to the pons. And then, yes, the 6th nerve, proximity of the 6th nerve to the 7th nerve, that also can be injured, involved in facial nerve injury. That can lead to a internal strabismus. So facial nerve injury, don't confine yourself only to Bell's palsy. There are so many other things to add. Okay, hope you understood. Yes, come on. Then moving on to the trigeminal nerve. What are the 3 components of the trigeminal nerve? Yes, ophthalmic, maxillary, and mandibular. What are the functional columns of the trigeminal nerve? We saw it under special, yes, special visceral efferent, the nerve of the first pharyngeal arch as mandibular nerve, isn't it? What are the muscles innervated by mandibular division of trigeminal nerve? Yes, come on, can you tell me? So what you see here is temporalis, this is masseter. So there are 4 muscles of mastication, temporalis, masseter, medial pterygoid, and lateral pterygoid. And 2 tensors, what are they? The 2 tensors are tensor tympani, tensor veli palatini. And the suprahyoid muscles, anterior belly of digastric, mylohyoid. So that's about the special visceral efferent column. And what was the other afferent column, you know? The general somatic afferent column. The general somatic afferent column is going to innervate the skin over the face, right? So the ophthalmic nerve, that will give rise to the lacrimal nerve. I'll just label it, yeah. So this is going to be the lacrimal nerve, skin of the upper part, the lateral part of the upper eyelid. This is the supraorbital nerve, forehead and scalp up to the vertex. This is the supratrochlear nerve, which is more medial, the middle of the forehead and scalp. This is the infratrochlear nerve. And this is the external nasal nerve going all the way to the tip of the nose. So that is the territory of ophthalmic division of trigeminal nerve. Coming to the maxillary division of the trigeminal nerve, this is the infraorbital nerve, which is the main continuation of the maxillary nerve. So the branches of the infraorbital nerve will supply the lower eyelid, the side of the nose, and the upper lip. And then this is the zygomaticofacial, zygomaticotemporal nerve, right? And coming to the mandibular division of trigeminal nerve, this is the mental nerve, the buccal nerve. I told you something about buccal nerve. Do you remember? The buccal branch of mandibular nerve piercing the buccinator. It is sensory, right? And this is the auriculo. This is the auriculotemporal nerve. And here please remember one important MCQ. Okay, yeah, this area here. The skin over the parotid gland, the skin over the angle of the mandible, it is not innervated by trigeminal nerve. It is innervated by a branch coming from the cervical plexus, which we call it as the great auricular nerve. Okay, so this is very, very important. So even in the cadaver in a spotter, they can shade this area and they can ask you. Once in a NEET PG entrance examination, they asked that the patient could not feel any sensation while shaving his beard. So that part, the skin over the beard area, the parotid gland, that is innervated not by trigeminal nerve but by the cervical plexus branch great auricular nerve. And this trigeminal nerve, it has three sensory nucleus. I've told you, this is the spinal nucleus that receives pain and temperature from face. This is the chief sensory nucleus that receives the touch sensation from face. And this is the mesencephalic nucleus in the midbrain that receives the proprioception from the temporomandibular joint and the extraocular muscles. Okay, moving on to the next slide. This is the trigeminal ganglia. It is also called the Gasserian ganglia, right? And this is situated in a fold of dura mater that's called the Meckel's cave, close to the apex of the petrous part of the temporal bone. From the trigeminal ganglia, can you make out? These are the divisions, the three divisions of the trigeminal nerve. Okay, the ophthalmic division of the trigeminal nerve, it's going to exit through the superior orbital fissure, and maxillary division of the trigeminal nerve, it's going to pass through the foramen rotundum. The mandibular division of the trigeminal nerve, it passes through the foramen ovale. And just appreciate this, okay? The motor root of the trigeminal nerve that comes from the motor nucleus, it traverses along the mandibular division of the trigeminal nerve to innervate those 8 muscles. The 4 muscles of mastication, the 2 tensors, and the anterior belly and mylohyoid muscle. Okay. So let's see the key points related to each division. So the ophthalmic nerve, it's going to divide into 3 main branches: the lacrimal nerve, the frontal nerve, and the nasociliary nerve. The lacrimal and the frontal nerve, they exit through the lateral compartment of superior orbital fissure. The nasociliary nerve, the main division of the ophthalmic nerve, that passes through the intermediate compartment of superior orbital fissure. So this is the lacrimal nerve. You can see it's supplying the lacrimal gland, the conjunctiva, the skin of the lateral part of upper eyelid, all that. And this is the frontal nerve. Okay, this is going to divide into supraorbital and the supratrochlear, right? This is the nasociliary nerve. Okay, this nasociliary nerve, it is important. Okay, you can see the nasociliary nerve crossing from lateral to medial over the optic nerve. This is the optic nerve. This is the nasociliary nerve. This nasociliary nerve will give rise to the posterior ethmoidal nerve that supplies the posterior ethmoidal sinuses and the sphenoidal sinus. This is the anterior ethmoidal nerve. The course of the anterior ethmoidal nerve is interesting. From the orbit, it will enter the anterior cranial fossa through the anterior ethmoidal foramen. And from the anterior cranial fossa, it passes through a slit on either side of the crista galli to enter the nose. And here within the nasal cavity, it will give rise to branches to supply the nasal septum as well as the lateral nasal wall in the antero-superior quadrant. Okay, it will also give rise to the infratrochlear nerve. It will give a communicating branch to the ciliary ganglia and the long ciliary nerves that supply the eyeball. Okay, and then it will end as the external nasal nerve. So these are the branches of ophthalmic division of trigeminal nerve to summarize. Okay, coming to next, the maxillary nerve. So we saw that the maxillary nerve through the foramen rotundum, it reaches the pterygopalatine fossa. This is the maxillary nerve. It gives off branches here. This is the pterygopalatine ganglia. It gives branches to the pterygopalatine ganglia. It gives the zygomatic nerve. This zygomatic nerve will pass through the inferior orbital fissure and it will terminate over the face as zygomaticofacial and zygomaticotemporal nerve. It will give rise to the postero-superior alveolar nerve. And then it will continue as the infraorbital nerve. The infraorbital nerve is the main continuation of the maxillary nerve. This infraorbital nerve will give rise to the middle and anterior superior alveolar nerve. The posterior-superior alveolar nerve, the middle superior alveolar nerve, and the anterosuperior alveolar nerve, they will be related to the corresponding wall of the maxillary sinus. They will supply the maxillary sinus as well as the dentition of the upper jaw. The anterosuperior alveolar nerve also supplies the lower part of the nasal cavity. Fine. Coming to the mandibular division of the trigeminal nerve, very important, okay. So this, it's been frequently asked in your exams also. It passes through the foramen ovale in the middle cranial fossa to enter the infratemporal fossa. Okay, in the infratemporal fossa, it will be related to the aortic ganglia. It will have a trunk. From the trunk, two branches. The nervus spinosum. This nervus spinosum is the one that you see here. This is the middle meningeal artery. So the nervus spinosum and the middle meningeal artery will pass through the foramen spinosum to enter the middle cranial fossa. And then it will give the nerve to medial pterygoid. This nerve to medial pterygoid, after supplying medial pterygoid, it will pass through the aortic ganglia to supply the tensa tympani and the tensa palatini. The trunk will further divide into anterior division and posterior division. From the anterior division, we get the deep temporal branches that supply the temporalis muscle. Okay, and then we have the pterygoid branches to supply the lateral pterygoid. This is the lateral pterygoid muscle, and then masseteric nerve to supply the masseteric muscle which sits over the outer surface of the ramus of the mandible, and one sensory branch, the buccal nerve, which pierces the buccinator to supply the overlying skin and the underlying mucosa. All these are motor branches supplying the muscle, right? Whereas this one is the only sensory branch from the anterior division of mandibular nerve, which has been asked repeatedly as an MCQ. Okay. Coming from the posterior division of the mandibular nerve, we get the auriculotemporal nerve, which arises as two roots. And between the two roots, you can see the middle meningeal artery passing through, right? And then we have this inferior alveolar nerve that supplies the dentition of the lower teeth through its branches. It enters the mandibular foramen. The mandibular foramen in the mandible. Before it enters the mandibular foramen, it will give rise to the nerve to mylohyoid, which pierces the spinomandibular ligament. It supplies mylohyoid plus the anterior belly of digastric. Okay, and then the third branch coming from the posterior division is the lingual nerve. This lingual nerve, it carries general sensation from the anterior two-thirds of the tongue. And because of its communication with the chorda tympani, I told you, right, two functions of chorda tympani is handed over This is the chorda tympani that joins the lingual nerve. This is the lingual nerve. Okay. Two functions of chorda tympani handed over to the lingual nerve. What is it? The preganglionic secretomotor fibers for the submandibular and sublingual salivary gland. And then taste sensation from the anterior two-thirds of the tongue. Another important point to remember, this lingual nerve, it is closely related to the duct of the submandibular gland. Okay, so they present a triple relation. We'll be talking about it while doing submandibular gland also. So any surgery of the submandibular gland, its duct, care should be taken to prevent injury to this lingual nerve, which is closely related to the submandibular duct, Wharton's duct. So that's about the mandibular nerve. In this condition, you can see vesicles confined to which territory of the trigeminal nerve? Ophthalmic division. Herpes zoster ophthalmicus. This, you touch the patient's cornea with a wisp of cotton, immediately closure of the eye, right? We call it as the corneal reflex. So now you can tell me, what is the nerve that carries sensation? The afferent component of the corneal reflex is ophthalmic division of the trigeminal nerve. So sensation from the eyeball, the cornea, the conjunctiva, right, everything from the orbit is carried by this ophthalmic division of the trigeminal nerve. The eyeball, sensation, ophthalmic division. Efferent, what is the muscle that closes the eyes? Quick closure of the eyes due to contraction of Orbicularis oculi, that is innervated by the 7th cranial nerve. So the afferent component is 5th nerve. The efferent component is 7th nerve. Injury either to the 5th or the 7th nerve, corneal reflex is lost. Nerve supply to the pointed area is, you can tell me, ophthalmic division of the trigeminal nerve. Okay, so if you see this picture, come on, yes, you can see, right, the tip of the nose is ophthalmic division of the trigeminal nerve. Not only that, the upper eyelid, right, and the tip of the nose, whereas the lower eyelid, the side of the nose and upper lip, maxillary division of trigeminal nerve. The lower lip, the chin, all that is mandibular division of the trigeminal nerve. And the skin over the parotid, over the beard area, the angle of mandible, from the cervical plexus, great auricular nerve. Okay, moving on to the next topic, high topic. Yes, we'll see the discussion over the glands of head and neck. Okay, the salivary glands, the lacrimal gland, the thyroid gland. So 60-year-old Mrs. Malavika attended the medicine OPD with complaints of fever, pain close to ear while eating, talking. On examination, a small reddish swelling was seen around the right ear. Blood test and fluid sample from the parotid gland, it confirmed the diagnosis of acute viral parotiditis, mumps, viral infection. The postganglionic secretomotor fibers to the parotid gland, yes, you can tell me, come on, reaches via the auriculotemporal nerve. Preganglionic nerve, very good, the lesser petrosal nerve. Come on, let's have a very quick revision of the key points related to parotid gland. So you know the parotid gland is the largest of the salivary gland, situated in the parotid region. What are the capsules or the coverings of the parotid gland? It has a true capsule, it has a false capsule. The false capsule is contributed by investing layer of deep cervical fascia. So this investing layer of the deep cervical fascia, and this is the parotid, it is going to split into two layers, a superficial lamella and a deep lamella. The superficial lamella will attach to the zygoma. Okay, it covers the superficial surface of the parotid gland, whereas the deep lamella, it attaches to the styloid process. And this part of the deep lamella that extends from the styloid process to the angle of mandible will form the stylomandibular ligament that separates the parotid gland and the submandibular salivary gland. It separates the parotid gland from the submandibular salivary gland. Another thing they recently asked over the entrance, one of the competitive exam was that any small swelling of the parotid gland, it produces severe pain. Okay, it is because this superficial lamella is thick, unyielding, very strong. Okay, so that even a small swelling, it produces severe pain. And even in this case, we saw a patient had like a pain around the ear during talking, eating, right? Because of the close relation of the parotid gland to the temporomandibular joint. Okay. So yes, that was asked recently. Okay. And then what are the structures that lie within the parotid gland? The one that is more superficial, close to the surface. So from superficial to deep. More superficial will be the facial nerve. And deep to that is the retromandibular vein. And more deeper, on a deeper plane, is the external carotid artery. So this facial nerve, we have seen that it enters the parotid gland, it divides into its 5 terminal branches over the face, which we call it as pes anserinus pattern, right? The retromandibular vein is formed by the union of the 2 terminal branches of external carotid artery. What are they? This one which goes up is the superficial temporal artery, and the other terminal branch, this is the maxillary artery. So the accompanying veins, superficial temporal vein and the maxillary vein, they unite to form the retromandibular vein that will divide into an anterior division and posterior division. Now, the nerve and the vein, they lie a bit closer together, okay? And the part of the gland, 80% of the parotid gland will lie superficial to the facial nerve. And the most common tumor of the parotid gland, pleomorphic adenoma, it involves the superficial lobe. So this is the deep lobe, 20% that lies beneath this facio-venous plane of Pate. Okay, so when you resect a tumor, make sure you're above the facial nerve and its branches to prevent its injury. Secretomotor pathway of the parotid gland. Yes, come on. Yes, it begins in the inferior salivatory nucleus, that is in the medulla. From that, the preganglionic parasympathetic fibers, they pass through the glossopharyngeal nerve through its tympanic branch, which is also called the Jacobson's nerve. This Jacobson's nerve, it will pierce the floor of middle ear. It will enter the medial wall of the middle ear. It will form a plexus there, which is called as the tympanic plexus in the medial wall of middle ear. From the tympanic plexus, we get the lesser petrosal nerve. And this lesser petrosal nerve will synapse in this aortic ganglia that is present in the infratemporal fossa. Okay. Now, the postganglionic parasympathetic fibers, they travel through the auriculotemporal nerve to reach the parotid gland. Okay. So, what they do in your competitive exams, like they give you all the components of this pathway and ask you to arrange it in a sequential arrangement. So, it is very important to memorize the secretomotor pathway. It's easy. Again, what is this syndrome called? You must be thorough with it, right? So this is the parotid gland. The secretomotor fibers to the parotid gland is brought through the auriculotemporal nerve. Whereas the skin over the parotid gland, the sweat glands over the skin of the parotid gland, the blood vessels in the skin of the parotid gland, they are all innervated by the great auricular nerve. Any trauma, a penetrating trauma to the face involving the parotid gland, its nerve supply. During the regeneration healing phase, you can see that, yeah, the secretomotor fibers, they are misdirected. They go and join the sensory fibers supplying the skin over the parotid gland. So what happens whenever you eat, there is salivation. Along with the salivation, the sweat glands, the blood vessels, all those are also stimulated. So perspiration, you sweat a lot, and the blood vessels vasodilatation, blushing, right? So this is called as Frey syndrome. Okay. So the skin over the parotid, great auricular nerve, supplying the skin, the blood vessels, the sweat glands, and the skin. The secretomotor fibers to the parotid gland, yes, that's coming from the auriculotemporal nerve. Moving to the parotid duct, can you identify the parotid duct in this image? Yes, emerging from the anterior border of the parotid gland. What is this muscle? Masseter. So you can see it winding around the anterior border of masseter, and then it is going to pierce this muscle. What is this muscle? What is the fascia covering it? The buccopharyngeal fascia. Okay. So superficial to that, we have the buccal pad of fat. This parotid duct, which is also called the Stenson duct, it pierces the buccal pad of fat, the buccopharyngeal fascia, and the buccinator muscle, the mucous membrane of the vestibule of the mouth. Once it pierces the buccinator, it has an oblique course between the buccinator and the mucous membrane of the vestibule and opens opposite the upper second molar tooth. So it is very frequently asked in an image-based question or in your spotter examination. And the next sub-question will be is like, what are the structures pierced by the parotid duct, or where does it open into? Okay. Scialogram is a contrast procedure where, yes, some contrast is injected into the parotid duct. Any irregularities, a stricture can be made out. This is scialolith stone formation. Okay, in the parotid, you can see that. And this is more common in the submandibular gland. Okay. Yes, now let's see about the submandibular salivary gland. Can you identify the submandibular salivary gland here? Yes. Where is it situated? In the submandibular region, in the digastric triangle, below the mylohyoid line. So this is the mylohyoid muscle. Okay. And this mylohyoid muscle will divide the submandibular gland into a superficial part, a large superficial part and a small deep part. Okay. And to identify, to orient to this image, yes, this is the styloid process. This is our mandible. This is the hyoid. This is the superficial part. This is the deep part, the mylohyoid. This is the hyoglossus muscle. Okay. So you see the superficial part of the submandibular gland, superficial to the mylohyoid, and the deep part between the mylohyoid and the hyoglossus. Okay. Here, this is a lingual nerve. This is the lingual nerve. This is the duct of the submandibular salivary gland, the Wharton's duct. Okay. Now, identify few nerves here. Okay. This is the hypoglossal nerve, the 12th cranial nerve, the nerve to mylohyoid. And I told you this is the lingual nerve, closely related to the Wharton's duct. This we call it as the triple relation of the lingual nerve to the Wharton's duct. So initially you can see it is above and lateral to the duct. Then you can see it winding around its lower border, and then it ascends medially. Okay, above and lateral, then hooks around its inferior border and ascends medially. This is called the triple relation of the lingual nerve to the Wharton's duct. Secretomotor pathway for the submandibular and sublingual salivary gland. It begins in the superior salivatory nucleus that is situated in the pons. From that, the fibers, they pass through the facial nerve. It's chorda tympani branch. And remember, the chorda tympani joins the lingual nerve, handing over the preganglionic parasympathetic secretomotor fibers. So this is the lingual nerve. That synapses in the submandibular ganglia, the postganglionic fibers for the submandibular salivary gland, it reaches directly. There is no any separate name for that nerve supplying it, right? Whereas to reach the sublingual salivary gland, the postganglionic fibers, they again pass through the lingual nerve to reach it. So lingual nerve is a bit complicated in this area. It has the preganglionic parasympathetic secretomotor fibers for the submandibular and sublingual salivary gland and postganglionic secretomotor fibers for the sublingual salivary gland. Understood? Okay. Here again you can see the stone form. This is actually the opening of the submandibular duct in the floor of the mouth on either side of the frenulum linguae. Can you see a calculi there? Cyalohylite, as I told you, it is more common in submandibular salivary gland because it is a mixed salivary gland. Parotid is entirely serous. Here it's a mixed, so it will have more of mucus, more viscid secretion, more calcium, and the drainage is against gravity, right? You can see that the submandibular salivary gland is below here, but the duct has to go up. Okay, so these make cyalohylite formation more common in the submandibular salivary gland. This picture was given in a recent NEET PG question. That's the cyalohylite in the submandibular salivary gland. Again, this is a cyelogram. Here's a contrast procedure. And yeah, recently they've asked like one question related to the nerves which are closely related to the submandibular gland, which can get injured during any procedure of the submandibular salivary gland. So this one, yes, you can tell me, that is actually the cervical branch of the facial nerve, which is related to the inferior surface of the submandibular gland, which is in contact with the skin. Just above that, this will be the branch above that. Can you tell me, running close to the lower border of the mandible? The marginal mandibular branch of the facial nerve, right? And remember in the previous picture, we saw the hypoglossal nerve, the 12th nerve, okay? And then the lingual nerve closely related to the Watten's duct, nerve to mylohyoid. All these are, of course, closely related to the submandibular salivary gland and can be injured, okay? And the marginal mandibular nerve usually runs along the lower border of the mandible, but in some of the patients, it can have a course like this, going below and then coming up. So it's always better to make an incision few centimeters below, 2 to 4 centimeters below the lower border of the mandible to avoid injury to the marginal mandibular nerve. If in case this nerve is injured, what will happen? Which muscles are paralyzed? The marginal mandibular nerve, it supplies the muscles of lower lip. So those are paralyzed, leading to facial asymmetry. Fine. Coming to the lacrimal gland. So this lacrimal gland, it has an orbital part and a palpebral part divided by levator palpebrae superioris muscle. The parts of the lacrimal apparatus, yes, you know, the lacrimal gland, the conjunctival sac, and then we have the lacrimal sac, isn't it? This is the lacrimal sac, and this will be the nasolacrimal duct that conveys the tear secretion into the inferior meatus. Can you help me trace the pathway now? Yes, it begins in the lacrimatory nucleus. The fibers are going to pass through the 7th nerve. Yes, greater petrosal nerve. This greater petrosal nerve will be joined by deep petrosal nerve. The deep petrosal nerve is a branch coming from the sympathetic plexus that surrounds the internal carotid artery. Now both the greater petrosal nerve and the deep petrosal nerve, they join to form the nerve of pterygoid canal. This nerve of pterygoid canal, it synapses in the pterygopalatine ganglia. The postganglionic fibers will pass through maxillary division of trigeminal nerve, its zygomatic branch, its zygomaticotemporal branch. Okay, and this zygomaticotemporal branch will hand over these postganglionic parasympathetic lacrimatory fibers to the lacrimal nerve, that is again a branch of the ophthalmic division of the trigeminal nerve. The lacrimal nerve finally supplies the lacrimal gland. So every component in this pathway is important, including the nucleus. Where is it situated? In the pons, close to the superior salivatory nucleus. The preganglionic fiber is nerve of pterygoid canal. The ganglia is the pterygopalatine ganglia. The postganglionic parasympathetic fiber is zygomaticotemporal nerve. Everything is important, right? Mr. Sushma, an active social worker, underwent thyroidectomy for her goiter 2 weeks ago, following which she presented to surgery OPD with complaints of severe painful cramps of muscles in her hands and feet. She was diagnosed with carpopedal spasm secondary to hypoparathyroidism. So they have sacrificed your parathyroids, which are situated over the posterior surface of the thyroid gland. Identify the correct statement. Superior parathyroid is located opposite C6 vertebral level. Parathyroid glands, they lie between true and false capsule. The trunks of the blood vessels and the parathyroids, they lie between the true and the false capsule. Inferior thyroid veins drain into left brachiocephalic vein. That is the correct answer. The arterial supply to the parathyroids is chiefly from the inferior thyroid artery. Okay. So the thyroid glands, it's located opposite C5, C6, C7 and T1 vertebra. It has two lateral lobes connected by the isthmus, right? Let us go into the key points. So this is the apex of the thyroid gland. This apex is sandwiched between two muscles. The one that you see here, this is the sternothyroid, and more medially we have the inferior constrictor. Why am I telling us this? Because any upward extension is not possible because it is sandwiched between these two muscles. Then you can see an artery and a nerve accompanying here. This artery is going to be the superior thyroid artery, which comes from the external carotid artery. And the nerve accompanying here is the external laryngeal nerve. This external laryngeal nerve, it supplies cricothyroid muscle, which can be frequently pinned in your spotter, right? This is the cricothyroid muscle. It is a tensor of vocal cord that helps you to increase the pitch of the voice. So, when we try to ligate the artery, this nerve is postromedial, okay? It lies postromedial to the artery. So, accidentally, if it gets injured, then the muscle paralyzed will be cricothyroid and the patient will present with a weak, husky voice. Right. Coming to the base of the gland. The base of the gland, it is related to inferior thyroid artery. That is a branch coming from the thyrocervical trunk, the first part of subclavian artery. And the nerve accompanying it is recurrent laryngeal nerve that supplies most of the muscles of larynx. It presents variable relation to the artery close to the gland. So the artery is usually ligated away from the gland, but still accidentally if we injure the recurrent laryngeal nerve, then the patient is going to present with a hoarse voice. So to identify here, can you make out? This is the inferior thyroid artery. That is the recurrent laryngeal nerve. Okay. This is the external laryngeal nerve. The isthmus of the thyroid gland. It lies opposite the second, third, fourth tracheal rings. And along the upper border, you can see the anastomosis between the anterior descending branch of superior thyroid arteries of both the sides. Upward extension from the upper border of the isthmus, this is the pyramidal lobe. Sometimes this pyramidal lobe can be connected to the hyoid by a fibrous structure that is called as levator glandulae thyroideae. Okay, and from the lower border of the isthmus, these veins emerging out will be the inferior thyroid veins. And if in case there is one extra artery to supply the thyroid, the arteria thyroidea ema, that can enter through the lower border of isthmus. Okay. Blood supply of thyroid is very important. It's a highly vascular endocrine gland, isn't it? So the blood supply to the thyroid, as I told you, it comes from the superior thyroid artery and the inferior thyroid artery. We have seen what are the nerves accompanying it. We've also seen what are they, the branches of. Coming to the veins, we have the superior thyroid vein. This will be the middle thyroid vein. And this will be the inferior thyroid vein. So we saw that there is a superior thyroid artery, inferior thyroid artery, and sometimes the arteria thyroidea ema. Here sometimes there can be a fourth vein, vein of Kocher. It's called the vein of Kocher. Okay. So this superior thyroid vein, middle thyroid vein, and the vein of Kocher, all of them, they drain into the internal jugular vein. Whereas the inferior thyroid vein usually drains into the brachiocephalic, most commonly the left brachiocephalic vein. This is again another important MCQ. Okay. So these are the parathyroid glands, the superior and inferior parathyroid glands located between the true and the false capsule of the thyroid. The true capsule is nothing but formed by the stroma of the thyroid itself. The false capsule is formed by the pretracheal layer of the deep cervical fascia. So this pretracheal layer of the deep cervical fascia, it encloses the thyroid and then it goes up to attach to the hyoid, to the thyroid, and there's one extension from that this pretracheal fascia covering the medial surface of the thyroid lobe to the cricoid. That is called as ligament of Berry. The recurrent laryngeal nerve lies behind the ligament of Berry. Okay, so why am I talking about this nerve is that since it is enclosed by the pretracheal fascia, you know, the cartilages of the larynx, all that is going to move during deglutition. So the thyroid gland, it moves during deglutition. Any thyroid swelling, goiter, anything, any thyroid swelling, it moves when you swallow something. So you usually ask a patient in the OP to drink some water when he comes with the swelling of the neck to check whether it's a thyroid swelling. Okay. So the superior inferior parathyroid gland, they lie between the true capsule and the false capsule. And location of the superior parathyroid, we saw, right? C6. This lies, inferior parathyroid may lie either above or below the loop of inferior thyroid artery. And the chief source of blood supply to the parathyroid is coming from the inferior thyroid artery. So we saw what will happen when there is injury to the external laryngeal nerve, when we are trying to ligate the superior thyroid artery, or injury to the recurrent laryngeal nerve, when we try to ligate the inferior thyroid artery. Similarly, during thyroid surgeries, this parathyroid, it looks more like a flat tissue on the posterior surface. It can be accidentally like compromised with the tumor tissue or something. Okay, then what will happen? Hypoparathyroidism will return in tetany-like features. What you see here in the picture is a carpopedal spasm. Okay, spasm of the hand muscles. Next, moving on to a very high yield topic. This image that you see here is very, very important. Lot of concepts behind this. Okay, so everything here you should be able to identify. Let me help you. Okay. You can identify the cervical vertebra there. the spine of the cervical vertebra. So let us orient to the image. This is anterior aspect and that's the posterior. Okay. Now, can you make out the trachea? What is behind the trachea? The esophagus. In front of the trachea, you can identify the thyroid gland, the two lobes connected by the isthmus in front. Okay. Now, this is the carotid sheath where we see the vein, the artery, and the nerve there. Coming to the identification of muscles, the key muscles in the neck, the sternocleidomastoid, and behind the trapezius, isn't it? Okay. And the pre-paravertebral muscles, scalenus anterior, scalenus medius. Okay. Now, let us identify few important nerves here. What is the nerve that lies in the tracheoesophageal groove? Come on. The recurrent laryngeal nerve branch of vagus. Within the carotid sheath between the artery and the vein, this is vagus nerve. And in the anterior wall of the carotid sheath, the nerve loop that we see there will be the ansa cervicalis. And what lies behind the carotid sheath? The cervical part of the sympathetic trunk. Am I right? Yeah. Okay. And to add few more, between the scalenus anterior in front and scalenus medius behind, we get to see the trunks of brachial plexus in the posterior triangle of neck, isn't it? And this nerve that you see running anterior to scalenus anterior, yes, come on, who can tell me? Is the phrenic nerve. So the same concept you can identify in different images, okay? If it is a cadaveric image or like another section, just understand the concept. A nerve running in the tracheoesophageal groove, recurrent laryngeal nerve. Within the carotid sheath, it's going to be the vagus. In front of the carotid sheath, ansa cervicalis behind, cervical part of sympathetic trunk. Any trunks lying between the scalenus anterior in front and scalenus medius behind. Anterior to scalenus anterior, phrenic nerve. Was that okay? Yes. So this is a very, very important diagram image. Okay. The deep fascia of the neck, we call it as deep cervical fascia. It is divided into 3 layers from outer to inner. To start with, this is the investing layer of the deep cervical fascia. Why is it called investing layer of the deep cervical fascia? When we trace it from anterior to posterior, okay, it completely surrounds the neck like a cervical collar. And inner to it, enclosing the thyroid gland, that's the pretracheal layer of the deep cervical fascia. Okay. And covering the anterior surface of the cervical vertebra, the pre and the paravertebral muscles, this is going to be the prevertebral layer of the deep cervical fascia. This prevertebral layer, yes, it is going to divide into 2 layers. That is the one in the front. This is the anterior layer of the prevertebral fascia, and this one behind, we call it covering the anterior surface of the cervical vertebra. It's the posterior layer of the prevertebral fascia. Okay. So you can identify it, the 3 layers in this image. Let us do it in this one also. Let us identify the 3 layers in this image also. So this one, the outermost, is the investing layer of the deep cervical fascia. The investing layer of the deep cervical fascia, we traced it from anterior to posterior, right? Here also, when you trace it from above to below, yeah, you can see that it encloses the space above the manubrium sterni, forming the suprasternal space of Burns. Okay. And then the next layer enclosing the thyroid gland, what is it called? The pretracheal layer. This pretracheal layer we saw, it encloses the thyroid gland. If you trace it up, it attaches to the hyoid, to the thyroid, and also send extensions to the cricoid cartilage also. And if we trace it further downwards, it will cover the anterior surface of the trachea and then merges with the apex of the fibrous pericardium. Okay, pretracheal layer. That is why the thyroid, it moves with deglutition because of the attachment of the pretracheal fascia to the laryngeal cartilages. So any swelling over the neck, whether to differentiate whether it's a thyroid swelling or it is some other lymph node swelling, what we do, we ask the patient to drink water. And if the swelling moves with deglutition, then we confirm it is a thyroid swelling because the thyroid gland is enclosed within the pretracheal fascia and attaches to the laryngeal cartilages which move during deglutition, right? Coming to the prevertebral layer, this one is the anterior layer of the prevertebral fascia, and behind that, posterior layer of the prevertebral fascia. Okay. Now, you see something else, a green color one. Can you tell me what is that? So, we saw this is the trachea, right? The larynx going to continue as the trachea. And behind that, that small narrow opening, that's going to be the pharynx, and which is going to continue down as the esophagus. So behind the pharynx, we see this fascia, this green color line that you see here. That's nothing but the buccopharyngeal fascia. Okay, so yes, we'll be talking about it. Identification of each layer is important because it has been asked repetitively as image-based question in your competitive examination. And deep cervical fascia is one important topic, okay? Okay, so let us talk details about each layer. So this is the investing layer of the deep cervical fascia. As I told you, this entire quick revision, rapid revision, I'm just going to tell you the key points, isn't it? It encloses two muscles. This one here is the sternocleidomastoid and that's the trapezius. So it encloses sternocleidomastoid and the trapezius. This area anterior to the sternocleidomastoid is the anterior triangle and this is the posterior triangle between the sternocleidomastoid and the trapezius behind. It forms the roof. The investing layer, it forms the roof for the anterior triangle as well as the posterior triangle. Okay, and then yes, it forms two thickenings. One is the, it is going to enclose the parotid gland. So if this is the parotid gland, this investing layer, it will split as a superficial lamella and deep lamella. The superficial lamella will attach to the zygoma and it forms the parotidomesenteric fascia, right? Parotidomesenteric fascia. Whereas the deep lamella will go and attach to the styloid process. This part extending between the styloid process and the angle of mandible is called the stylomandibular ligament. So these are the two thickenings of the investing layer of deep cervical fascia. It encloses two glands. Okay, on its way, when we trace the investing layer from below upwards, it splits to enclose the submandibular salivary gland. And here in the face, it splits to enclose the parotid gland. And this stylomandibular ligament, it separates the parotid gland and the submandibular salivary gland. And as I told you, it encloses two spaces while we trace it. One I told here, right, above the manubrium sterni, the suprasternal space of Burns. This suprasternal space of Burns, it has the sternal head of sternocleidomastoid, the jugular venous arch that connects the anterior jugular veins of both the sides, the interclavicular ligament that connects the clavicle of both the sides, the medial end of them, and some lymph nodes. Contents of the suprasternal space of Burns. And the other space is that over the middle one-third of the clavicle, it encloses the supraclavicular space. In the supraclavicular space, we can see that the external jugular vein, it pierces the investing layer of deep cervical fascia that forms the roof of the posterior triangle to enter into the subclavian vein. So the termination of external jugular vein is related to the supraclavicular space. So you'll be able to identify investing layer of the deep cervical fascia in a horizontal as well as in a sagittal section, and its modification enclosing two muscles, two glands, two thickenings, roof or two triangle, and two spaces. Easy? Come on. Next is the pretracheal layer of the deep cervical fascia. As you see here, the pretracheal fascia, you can see it is enclosing the thyroid gland, isn't it? And from the, you see this is the lateral lobe, right? From the medial aspect of the lateral lobe, the pretracheal fascia that covers that aspect, it sends an extension to attach to the cricoid cartilage. Do you know what is it called? The ligament of Berry. The ligament of Berry extends from the thyroid, okay, to the cricoid cartilage. And the recurrent laryngeal nerve, it lies behind the ligament of Berry. This is one important landmark during surgery. Okay. And we have seen, because of the enclosure of the thyroid gland by the pretracheal fascia and its attachment to the hyoid and the laryngeal cartilages, we know that the thyroid and the thyroid swelling, they move during deglutition. Once we trace it down, it's going to merge with the apex of fibrous pericardium. Okay, moving on to the prevertebral layer of the deep cervical fascia. This prevertebral layer, we saw it is dividing into anterior and posterior layer. And then you can appreciate here, it covers the muscles that form the floor of the posterior triangle like a carpet. Okay, so in the posterior triangle, the investing layer will contribute to the roof of it. Okay, and this prevertebral layer will cover the muscles in the floor. And in between scalenus anterior and scalenus medius, this prevertebral layer will send a covering, an extension of it to cover the trunks of the brachial plexus and the subclavian artery. We know the trunks of the brachial plexus, they are going to supply the upper limb, and subclavian artery is going to continue as the axillary artery. Okay, so this extension of the prevertebral fascia is called as the axillary sheath. Okay, so that's about the three layers and their modifications. Now going to two important spaces between these layers. Yes, now I will take the highlighter and mark a space, okay? You have to tell me the boundaries of it. Can you see this blue color here? Yes, you can tell me what are its boundaries. Anteriorly, it's bounded by that green color. What fascia was that behind the esophagus or the pharynx? Yes, come on. The buccopharyngeal fascia. Right? Can you identify the same here? Right? Buccopharyngeal fascia. The green one that you see here. And the posterior boundary of this space is formed by the anterior layer of prevertebral fascia, isn't it? So to shade it here, this will be, okay, yeah. So this is the space we are talking about between the buccopharyngeal fascia in front and the anterior layer of the prevertebral fascia behind. Okay, yes. Now, this space, it is called as retropharyngeal space. The retropharyngeal space is limited laterally by the carotid sheath and its contents. And medially, there's a septum separating it from a similar space on the opposite side. It is also called the space of Gillette. Okay? Yeah. And then, what does this space contain? It has the retropharyngeal lymph nodes. So enlargement of the retropharyngeal lymph nodes can produce a swelling here on either side of the midline. We call it as the paramedian swelling. Okay, so what are the boundaries anteriorly, posteriorly and laterally? Okay, now coming to another important space, I'll shade it in, yeah. So this one here, you can tell me the boundaries. Front by anterior layer of prevertebral fascia and behind by the posterior layer of prevertebral fascia. Okay, this space I can show you here also. This one between the anterior and the posterior layer. Okay, yes. So this space above, it is limited by the base of the skull. And below, if you track it now, what will happen? This posterior layer of the prevertebral fascia, it continues to cover the anterior surface of the upper thoracic vertebra and it will lead on to posterior mediastinum. Okay? Yes. So, tuberculosis of the cervical vertebra, the abscess, the cold abscess formed here, can track on into this space that lies between the anterior and the posterior layer of the prevertebral fascia and can extend all the way down to the posterior mediastinum where a lot of important structures are there. Hence, this space is called as the danger space of neck. Why is it called danger space? Because of its communication below with the posterior mediastinum. Okay, and any swelling here, it's going to produce a midline swelling or a median swelling. Okay, in retropharyngeal space, it was a paramedian swelling, whereas in the danger space of neck, it will be a midline swelling. Okay, come on, yeah. Now, let's move on to the key muscle of the neck. Can you tell me what is this one I'm pointing out? Yes, sternomastoid. What are the important things that you should definitely know about sternocleidomastoid? Of course, origin you can tell me. From the sternum, from the clavicle, inserting into the mastoid process. Well, yeah. What is its innervation? Spinal accessory nerve. And we have just now learned, revised that it is going to be enclosed within the investing layer of deep cervical fascia. The anterior border, it contributes to the anterior triangle of neck. The posterior border will contribute to the posterior triangle of the neck, isn't it? And yes, in the posterior border at a particular point, we can see the spinal accessory nerve emerging. It's hooked around by the lesser occipital and the other branches of cervical plexus going towards the ear, great auricular nerve running horizontally, transverse cervical. And then we'll have the supraclavicular nerves. Okay, here we'll have the C3, C4, and then the dorsal scapular nerve. Okay, I'll label it for you. So this is the spinal accessory nerve. This one is the lesser occipital, yeah, from the cervical plexus ventral rami of C2. This one is the great auricular C2, C3 ventral rami. And this is the transverse cervical cutaneous nerve. Again, C2, C3, these are the supraclavicular nerves. The medial, the intermediate and lateral, C3, C4, okay? Dorsal scapular nerve. So this point is called the nerve point. On the posterior border, midpoint, just close to it, we have the nerve point. And at this point exactly, we can see the spinal accessory surrounded by superficial cervical lymph nodes, okay? And during clearance of the abscess related to lymph nodes, extreme care should be taken to avoid injury to the spinal accessory nerve. It supplies not only sternocleidomastoid, it also supplies trapezius. What is the action of sternocleidomastoid? Imagine being slapped on the right cheek. What will happen? The chin will turn to the opposite side, left, and the head will be the same side of the shoulder. Chin to the opposite side and the head same side as the shoulder. isn't it? Okay. Of course, it is an accessory muscle for respiration also. Inspiration. So we can see this is the sternocleidomastoid enclosed by the investing layer of the deep cervical fascia. Can you tell me what is this vein running on the anterior surface of the sternocleidomastoid? Yes, very good. External jugular vein. Okay. So it runs on the anterior surface of the sternocleidomastoid. This is the supraclavicular space, where 1.25 centimeter above the clavicle, this external jugular vein will pierce the roof, the investing layer of the deep cervical fascia, to terminate into the subclavian vein. And you can also see the supraclavicular nerves. Okay. So this is a sternocleidomastoid, right? So this swelling that you see here is related to the upper part of the anterior border. This is called the branchial cyst. Whereas here, this one related to the lower part of the anterior border is the branchial fistula. Okay. So just for now, remember their location. The details of it will be given while doing your embryology chapter. Okay. So branchial fistula, the external opening towards the anterior border, lower part. Cyst is related to the upper part. Okay. And then otitis media. The pus from that can escape through the mastoid process and enter into the upper part of the sternocleidomastoid. That is called as the Bizold abscess. Another one thing which is very commonly asked. So this is spasm of the sternocleidomastoid. The right and left side, right? Okay. So you can see the left side muscle undergoing spasm. What is happening? The chin is turned to the right and the head is same side of the shoulder. Spasm. This twisted neck, it's called as the torticollis or wry neck. Okay. So it could be congenital or it could be acquired. What is the reason for congenital torticollis? The most common causes during vaginal delivery of the baby, while we're trying to pull the baby's head out, okay, stretching of the neck can cause rupture of the vessels that supply sternocleidomastoid. So it can go for fibrosis, yes, and contracture, leading to congenital torticollis. And in adult, maladjustment of the pillows during sleeping, improper positioning of the neck, that can cause spasm of the sternocleidomastoid. Okay. And blood supply of sternocleidomastoid, the upper 1/3 of the muscle receives the blood supply from occipital artery. Sternocleidomastoid branch is coming from occipital artery. And the middle 1/3 of the muscle gets its blood supply from the sternocleidomastoid branches of superior thyroid artery. And the lower 1/3 gets the blood supply from the suprascapular artery. Okay, this is also important. Now, moving on to another important topic, the suprahyoid and infrahyoid muscles. Where is the hyoid? Here. What is the vertebral level of hyoid? C3. So, what is expected out of you? You should know the names. You should able to identify those muscles in the given image, give its nerve supply. That's it. Okay. So, coming to the infrahyoid muscles. Can you help me identify those? Okay. 1 and 2 are close by, right? Yes. 3 is here and 4. 1 is sternohyoid. And just sitting next to it is the superior belly of omohyoid. If there is a superior belly, then definitely there should be an inferior belly. Where to look for it? In the posterior triangle. This is the inferior belly of omohyoid. Okay. And 3 is the sternothyroid that lies deeper to the sternohyoid muscle, isn't it? And 4. So the sternothyroid, it goes and inserts into the oblique line of thyroid cartilage. That is why it's called sternothyroid. And the upward continuation of this muscle, starting from the oblique line of thyroid cartilage to insert into the hyoid, that is for thyrohyoid. Okay, so you know the name, you'll be able to identify it in the image. Now, other thing they frequently ask in this topic is nerve supply. So where is the nerve supply coming from? Ansa cervicalis. How is the ansa cervicalis formed? Yes, C1, C2, C3, ventral rami. The C1 fibers will accompany the hypoglossal nerve for some time, and after that it descends down. So this part of the C1 fibers descending down, it's called the descendens hypoglossi, or the superior root of ansa cervicalis. Is that fine? And then coming to the ventral rami of C2 and C3, they too unite to form the inferior root of ansa cervicalis. Okay, from the nerve loop, we get branches that supply the inferior belly of omohyoid, sternohyoid, sternothyroid. Okay, from the superior root, branches go to supply the superior belly of omohyoid. And coming to the important part, the C1 fibers, the ventral rami of C1 fibers, without forming the ansa, exclusively they supply the thyrohyoid and geniohyoid. So this is all very important. If someone asks you, the nerve supply to superior belly comes from superior root. Sternohyoid coming from the loop of ansa. Thyrohyoid, it's from the exclusively C1, not through ansa. Got it? Now let's move on to the suprahyoid muscles. So you can see the hyoid bone here, right? Let us identify the muscles. 1, 2, 3 and 4. 1, come on, tell me, what is 1? Anterior belly of digastric, originating from the digastric fossa of the mandible. 2 is mylohyoid, right? And 3 is stylohyoid, coming from the styloid process. And the 4th one, yes, posterior belly of digastric. So you know the names. Now, nerve supply to these muscles. The anterior belly of digastric and the mylohyoid, they are innervated by nerve 2 mylohyoid, a branch of the inferior alveolar nerve that comes from the posterior division of mandibular nerve, right? Which is again a branch of the trigeminal nerve. Of course, all this is important because they can ask you a question. Anterior belly of the digastric is innervated by 6th nerve, 7th nerve, 5th nerve, 8th nerve, right? So you might not have the direct answer in the options always. You should be able to take it to trigeminal nerve in that case. Yes, it is important. Coming to the nerve supply of stylohyoid and posterior belly of digastric, it's by the facial nerve, the 7th nerve. These muscles, I call it as the SPB muscle, because during dissection, there's always a confusion which one is above and which one is below. So remember, the S is above, stylohyoid is above, the PB is below. Okay, SPB muscle. Of course, yeah. And another important function, of course, the suprahyoid, infrahyoid muscles, they are going to move the larynx and cause help in deglutition, all that okay. The suprahyoid muscles, specifically, what are they going to do is, they depress the mandible. What do you mean by depressing the mandible? Yes, they open the mouth, okay? They lower the mandible to open the mouth. Okay, so please remember that. Moving on to the next high topic in head and neck, the midline structures of the neck. So you're expected to know what are the structures that lie in the midline, vertebral level, and identify it. Okay, it can be an image-based question. It can be used in your spotter. Very important. So to start with, yes, you can tell me what is this? The point of fusion of the two halves of the mandible, symphysis mentae. Below that, you see a fibrous raphe This is the mylohyoid muscles, okay? The mylohyoid muscles of both the sides, they meet in the midline, they form a raphe, that is what you see here. And above that, we get to see the floor of the mouth with the tongue. So because of the meeting of the mylohyoid of both the sides, okay, together it's called the diaphragma oris. And in the midline, it's the median raphe. And this is the hyoid bone. Can you tell me what is its vertebral level? C3. Below that, we can see the thyroid cartilage. Vertebral level of the thyroid cartilage, C4 and C5. And this is the cricoid cartilage, vertebral level, C6. Then we see the trachea. The isthmus, can you tell me what is its posterior relation? It sits over the second, third and fourth tracheal rings, isn't it? Above the manubrium sterni, we have seen that the investing layer of the deep cervical fascia splits to enclose that suprasternal space of Burns. Okay. Yeah. Few more to add here. This membrane extending between the hyoid above and the thyroid below, it's called the thyrohyoid membrane. This thyrohyoid membrane is pierced by two structures, a nerve and an artery. What are they? The internal laryngeal nerve, a branch of superior laryngeal nerve that comes from vagus, and then the superior laryngeal artery, that's a branch of the superior thyroid artery. Okay, and then we have this part between the cricoid below and the thyroid above, the median cricothyroid ligament. Yeah, and this one between the cricoid above and the trachea, we have the cricotracheal membrane. Sometimes from the upper border of the isthmus, you can see an extension of the glandular tissue. What will we call it as? Yes, the pyramidal lobe. And sometimes we can see a fibrous strand extending from the pyramidal lobe to the hyoid. What will that be? Levator glandulae thyroideae, a fibromuscular glandular strip. Okay. And inferior border of the isthmus, the lower border of the isthmus will be related to the inferior thyroid veins, and if the arteria thyroidea ema is present, a branch, an occasional branch coming from arch of aorta, if it is present, that will enter the thyroid through the inferior border, lower border of the isthmus. Okay, and we have seen the contents of the suprasternal space of Burns. Okay, so these are all the midline structures in the neck. Now let's go to the quick revision of the triangles of neck. Yes, the anterior triangle, it is bounded by the anterior border of the sternocleidomastoid, the midline structures, the midline of the neck, the lower border of the mandible extending to the mastoid process, isn't it? What are the subdivisions of this anterior triangle? So, this is the posterior belly. This is anterior belly of the digastric, anterior belly, posterior belly and the lower border of mandible. This triangle, we are going to call it as the digastric triangle. The digastric triangle will have the submandibular gland and all the structures related to the submandibular gland. The posterior aspect of the submandibular gland is going to be related to facial artery, isn't it? And then the cervical branch of the facial nerve, the common facial vein, the facial vein, and then submandibular lymph nodes, all that will be the superficial contents, okay? And also the hypoglossal nerve, the first part, the lingual artery, all that will be related to the digastric triangle, okay? And then this triangle, okay, between the posterior belly of the digastric, this muscle, can you tell me, is the superior belly of omohyoid. This is inferior belly. So bounded by the posterior belly of the digastric, the superior belly of omohyoid, and the anterior border of sternocleidomastoid, where we have the carotid artery, internal jugular vein, vagus nerve, and lot more important structures. Yes, carotid triangle. And coming to the less significant ones, bounded by the anterior border of the sternocleidomastoid, the midline of the neck, and the superior belly of omohyoid. This is called the muscular triangle, because here we have sternohyoid, sternothyroid, and beneath that we get to see the cartilages of the larynx. One more triangle, the anterior belly of digastric of both the sides with the hyoid below. So you can make it out only in the midline, right? Okay. Yes, this is going to be the submental triangle. So the submental triangle can be contributed only by both the sides. Okay. So on the whole, each side will have 3.5 triangles. The digastric triangle, carotid triangle, muscular triangle, and a part of the submental triangle. Am I right? Now, moving on to few important points, Alan. Okay. The floor of the digastric triangle is contributed by this muscle. Yes, you can tell me. It is the mylohyoid. Just behind that, this one here, that's the hyoglossus. And we can also see part of the middle constrictor. Okay. Similarly, the floor of the carotid triangle, 4 muscles contribute to it and it is important. We have the thyrohyoid, this one, hyoglossus, middle constrictor coming from the hyoid, and the inferior constrictor coming from the thyroid. These are the 4 muscles contributing to the floor of the carotid triangle. Yes. Now, let's go through the carotid triangle. What are the structures or the contents of the carotid triangle? That's easy. Yes. So, we have to tell that we have the carotid sheath in the carotid triangle. And within the carotid sheath, we get to see the common carotid artery. The common carotid artery at the level of upper border of the lamina of the thyroid cartilage, it is going to divide into internal carotid artery and external carotid artery, isn't it? So the common carotid and internal carotid will lie within the carotid sheath. The external carotid, it exits out, it gives rise to 8 branches, and 5 branches of the external carotid is seen in the carotid triangle. Okay. And yes, not only that, we also get to see this one, the vein there within the carotid sheath laterally. The arterial component is medial. Laterally, we have the venous component, the internal jugular vein. Now, between the artery and the vein, bit deep, that's the vagus nerve. The anterior wall of the carotid sheath is related to ansa cervicalis. Posterior wall is related to cervical part of the sympathetic trunk. Apart from this, we get to see 2 other important nerves which you can't afford to forget. Okay, so this one that you see here is, you can tell me, is the spinal accessory nerve. Of course, we see the spinal accessory nerve in the topmost part of the carotid triangle, and this one here is the lastest of the cranial nerves, the hypoglossal nerve, right? So yes, in addition to vagus nerve, you have to remember others also. Ansa cervicalis, cervical part of the sympathetic trunk, and then the spinal accessory hypoglossal nerve. Okay. We also get to see part of the parotid gland, and then the lymph nodes, the deep cervical lymph nodes, the jugulodigastric, jugulo-omohyoid nodes as content of the carotid triangle, isn't it? So this vagus nerve, the vagus nerve, its entire course in the neck, it lies within the carotid sheath, and its branches in the neck are really very, very important. Branches, the cervical cardiac branches that goes for the formation of cardiac plexus, branch to supply the carotid body and carotid sinus. Okay. And then pharyngeal branch of vagus to supply the muscles of pharynx, except stylopharyngeus, that is innervated by glossopharyngeal nerve. It gives off the superior laryngeal nerve The superior laryngeal nerve will divide into internal laryngeal nerve. We just now saw about it. It pierces the thyrohyoid membrane. It traverses through piriform fossa to supply the mucosa above the level of the vocal cord. So injury to this internal laryngeal nerve can produce aspiration. Yes, I will be repeating all this for the internal laryngeal nerve throughout our revision. Okay, it is important. Coming from the superior laryngeal nerve, piercing the thyrohyoid membrane, traversing the piriform fossa to innervate the mucosa above the vocal cord. Yes. And then the external laryngeal nerve, it is motor, entirely motor to supply the cricothyroid, that is the tensor of the vocal cord. And lastly, the right recurrent laryngeal nerve. Why right recurrent laryngeal nerve? Yes, it's just the right recurrent laryngeal nerve because the left recurrent laryngeal nerve is given off in the thorax. So these are the branches of vagus given off in the neck. Coming to the external carotid artery and its 5 branches in the carotid triangle, let's identify. That one important landmark here to identify the branches of the external carotid artery is a hyoid bone. Okay, so this artery, so you have identified the common carotid here. This is the internal carotid artery. This is the external carotid artery, right? So this one coming from the external carotid below the tip of the greater corner of the hyoid going towards the thyroid gland. Yes, you are right. Superior thyroid artery. Exactly opposite the tip of the greater corner of the hyoid is a lingual artery. Above the tip of the greater corner of the hyoid bone, that is the facial artery. Yes, facial artery, though we see it on the face, it has a cervical course. It is related to the carotid triangle. And then opposite to the origin of the facial artery from the posterior aspect of external carotid, that is the occipital artery. And the only medial branch of external carotid artery which is going to ascend along the pharynx, the ascending pharyngeal artery. These are the 5 branches of external carotid artery found in carotid triangle. Apart from that, please remember, this facial artery is not only related to the carotid triangle but also to the digastric triangle. Similarly, lingual artery also, we can see it in the carotid triangle, its origin, and then its rest of the course is in the digastric triangle, and its course divided into 3 parts by which muscle? Hyoglossus. Okay, hyoglossus will divide the course of the lingual artery into 3 parts. More important, occipital artery is related to the carotid triangle. You can also see the occipital artery in the topmost part of the posterior triangle, in the occipital triangle, and in the roof of the suboccipital triangle. Okay, yes. So let's now move on to the next important topic, posterior triangle of the neck. Yes, you can tell me what are the boundaries. Anteriorly, it is bounded by the posterior border of sternocleidomastoid, posteriorly by the anterior border of trapezius, and below middle 1/3 of the clavicle, isn't it? Apex where these two meet. The roof of the posterior triangle of the neck, we get to see the skin, superficial fascia, the platysma in the lower part, and then the investing layer of the deep cervical fascia. Also, the external jugular vein. It lies in the lower part of the roof of the posterior triangle. What are the structures in the floor of the posterior triangle of neck? Okay, so scalenus medius, scalenus posterior, and then levator scapulae, splenius capitis, and high above the vertical fibers of semispinalis capitis. So let us mark the muscles in the floor. So this is scalenus medius, and then we have the scalenus posterior in a long neck, people. Okay, it's much visible. And this is levator scapulae, splenius capitis, high above semispinalis capitis. These muscles are covered by prevertebral layer of deep cervical fascia. Okay, it carpets it. So the investing layer of the deep cervical fascia, it lies in the roof. The prevertebral layer, it lies in the floor. And this inferior belly of omohyoid is going to subdivide this triangle into a upper part. The larger upper part is called the occipital triangle, and the lower part, which lies above the clavicle, it's called the supraclavicular triangle or the subclavian triangle. Okay, now let us see the contents of these triangles. So occipital triangle, what are the contents? We can see the spinal accessory nerve as the highest content, hooking around it and going upwards. Lesser occipital nerve from the cervical plexus, ventral rami of C2, going towards the auricle, great auricular nerve. Okay, C2, C3 ventral rami. It supplies the skin over the angle of mandible, skin over the parotid gland. And this one here running horizontally, the transverse cervical cutaneous nerve. Okay, again ventral rami of C2, C3. And these are the supraclavicular nerves. Parallel to spinal accessory will be ventral rami of C3, C4. And this is the dorsal scapular nerve. Okay, and yes, as I told you, what are the three triangles related to the occipital artery? Carotid triangle, occipital triangle and suboccipital triangle. Can you appreciate the occipital artery here? Apart from that, the superficial cervical artery, transverse cervical artery will also be seen in this triangle. Okay, now moving on to the contents in the, I'll just show you the external jugular vein here. In the roof, this is the external jugular vein. Now moving on to the contents of the lower part of the posterior triangle, the supraclavicular or the subclavian triangle. This is the scalenus medius muscle. This is scalenus anterior muscle, isn't it? We get to see the trunks of brachial plexus between scalenus anterior in front and scalenus medius behind. Yeah? And we get to see the third part of subclavian artery. Yes, this is the subclavian vein that receives the external jugular vein. Okay, and branches from the supraclavicular part of the brachial plexus. Can you tell me which will be related to the triangle here? The long thoracic nerve with the root value C5, C6, C7. The dorsal scapular nerve with the root value C5. Accessory branch to phrenic nerve with the root value C5. Okay, and coming from the subclavian artery, we'll be able to see dorsal scapular artery, transverse cervical artery, suprascapular artery. Okay, so this is the subclavian vein, the subclavian artery. This one following parallel to the clavicle, that is the suprascapular artery. Okay, yeah, this will be the dorsal scapular artery from the third part. So this is going to be the superficial cervical artery. Okay, and what are the branches from the upper trunk of the brachial plexus? The suprascapular nerve and nerve 2 subclavius. Okay, and remember there are going to be a lot of lymph nodes also in the posterior triangle. So any procedure, okay, you see an abscess of the lymph node. Yeah, we try to remove the abscess. Care should be taken not to injure the spinal accessory nerve. The spinal accessory nerve, it supplies sternocleidomastoid and trapezius. We saw it in the carotid triangle. We are seeing it in the posterior triangle as the highest content, right? Okay. And extreme care should be taken to avoid injury to the brachial plexus. What will happen if the upper trunk of brachial plexus is injured? Erb's palsy. Upper trunk, lower trunk, Klumpke's palsy, which will present with claw hand, right, honor syndrome, all that. Also, during catheterization of the subclavian vein, yeah, care should be taken. And then aneurysm of the subclavian artery can compress the trunk of the brachial plexus. So all these are the clinical anatomy related to the posterior triangle. Okay. Now let's see about the 11th cranial nerve, which we call it as the accessory nerve. Why do you think it's called accessory nerve? It has two components, cranial and spinal. This cranial accessory will assist the vagus, right? Hence, it is called as accessory nerve. Cranial accessory nerve will begin in the medulla, the nucleus ambiguous of the medulla, and it will exit through the posterolateral sulcus of medulla. Spinal accessory, why do you think it's called spinal accessory? It is going to come from the, yes, the anterior gray horn, the motor neurons in the C1 to C5 spinal segment. And then it will pass through the foramen magnum to enter the cranial cavity. Now, both this cranial and the spinal accessory nerve, they pass through which foramen? The intermediate compartment of the jugular foramen, the 9, 10 and 11 cranial nerve. So one in NEET entrance examination, NEET PG entrance examination, they have asked that which are the nerves that share a common dura mater. The 10th nerve and the accessory nerve, they are surrounded by one common sheet of dura mater, right? Once they exit out of the jugular foramen, this cranial accessory, it will be distributed through the branches of the vagus to supply the muscles of soft palate, pharynx. Okay. What happens to the spinal accessory nerve? The spinal accessory nerve, we saw it in the carotid triangle. We saw it in the posterior triangle, supplying two muscles. What are they? Sternocleidomastoid and trapezius. What will happen in its injury? Paralysis of the sternocleidomastoid and trapezius muscle. What are the conditions or mode of injury to this spinal accessory nerve? So any procedures in the carotid triangle, carotid endarterectomy, or in the posterior triangle, any lymph node abscess clearance, okay? And the syndrome related to jugular foramen, what is it? Wernicke syndrome. Fracture base of the skull involving the jugular foramen, the 3 cranial nerves, 9, 10, 11, is called as the Wernicke syndrome. So all this can lead to injury of the spinal accessory nerve, paralysis of sternocleidomastoid and trapezius. So what will be the patient's symptoms? We need trapezius to elevate, shrug the shoulders. So if it is paralyzed, patient cannot shrug the shoulders. Okay. And a typical shoulder drop will be observed. Okay. The middle fibers of the trapezius has to pull the scapula towards the midline. So if the middle fibers, the trapezius is paralyzed, the scapula will not be like pulled towards the midline, it will go laterally. That is called as lateral winging of scapula. Okay, the protractors of the scapula serratus anterior, the retractors of the scapula, the middle fibers of the trapezius along with the rhomboids muscle. Okay, and when you want to lift your hand above the head, like you dust the fan, or painting the ceiling, combing the head, we call it as the overhead elevation of arm. That is produced by the contraction of upper and lower fibers of trapezius along with the serratus anterior muscle. So if this spinal accessory nerve is injured, then overhead elevation of arm becomes difficult. Okay, so that was about the posterior triangle and accessory nerve. Now let's move on to suboccipital triangle. Of course, they have asked this over your previous examinations, a very important topic. What are the boundaries of this suboccipital triangle? The roof of the suboccipital triangle, only when you remove these muscles, you'll be able to see it. It's formed by the semispinalis capitis and the longissimus capitis. Suprolaterally, it is bounded by this one. What is it? Obliquus capitis superior. Okay. Infralaterally, it is bounded by this muscle. What is it? Obliquus capitis inferior. And medially, yes, we get to see rectus capitis posterior major. If there is a major, there should be a minor, right? So this is the rectus capitis posterior minor that is not included as a boundary for the suboccipital triangle. So it's just the rectus capitis posterior major, obliquus capitis inferior, obliquus capitis superior. What lies in the floor of the suboccipital triangle? This is the atlas bone. What we see here is the posterior arch of the atlas. Okay. And this posterior arch of the atlas is connected to the occipital bone by this membrane. Yes, can you tell me what is it? Posterior atlanto-occipital membrane. Okay. So once there was a question, an image-based question. The posterior arch of atlas was given, an arrow was pointed over there. What is it related to? Okay, so the contents of the suboccipital triangle, we get to see the suboccipital venous plexus. Only if we remove this venous plexus during dissection, the other contents, the boundaries will become clearly visible. And then we get to see the suboccipital nerve. Okay, C1. So you have the posterior arch of atlas, directly resting over it is the suboccipital nerve. And above that, you see this artery here. It's the third part of the vertebral artery. So this vertebral artery will be related to the atlas at 2 points. You can see the transverse process of the atlas here, the foramen there. So you can see the second part of the vertebral artery coming out through the transverse process, the foramen in the transverse process of the atlas. And the third part is related to the posterior arch of the atlas. So this course of the vertebral artery in the suboccipital triangle is the third part. And it passes through the foramen magnum to continue within the cranial cavity. We call it as the fourth part. I'll just add to this part. The roof will be related to the greater occipital nerve, and the supralateral part of it will be related to the occipital artery. So this is the greater occipital nerve. Okay, laterally the roof will be related to the occipital artery. So the boundaries, the contents of the suboccipital triangle is of course important. I'll read it out for you. A phase 3 part 2 MBBS student after a heavy lunch from men's hostel got ready for the afternoon theory class. The surgery lecturer was elaborating the importance of thyroid swelling. He sat in the first bench and began to take notes. Do you people take notes to your class? Very good. After a while, he yawned widely. To his surprise, sadly, he could not close his mouth after that. The jaw was stuck. The muscle that underwent spasm in this condition is, yes, the one that helps you to open your mouth, the lateral pterygoid. Okay, so this muscles of mastication is a very high topic, very, very, very important. You should know their names. You should be able to identify those muscles in the image, attachments, action, nerve supply, everything about it is important. Come on, let's look into the concepts. So what are the muscles of mastication? Come on, the names. We have the temporalis, masseter, the medial pterygoid, and the lateral pterygoid, the 4 muscles of mastication that's going to move the mandible, isn't it? So temporalis, you can identify where it is located and originating from, yes, from the temporal fossa of the temporal bone, and it inserts into the coronoid process of mandible. Where do you see the masseter? Over the outer surface of the ramus of the mandible, isn't it? It originates from the zygoma and inserts into the outer surface of the ramus of the mandible. It is an example for cruciate fibers. Okay, and then the medial pterygoid is seen only after you remove the ramus of the mandible. because it attaches to the inner surface of the ramus of the mandible. It has two heads. The superficial head, it comes from the maxillary tuberosity on the posterior surface of the maxilla. And the deep head, it comes from the medial surface of lateral pterygoid plate. That's why we are calling it as deep head. Medial surface of lateral pterygoid plate. The lateral pterygoid muscle has an upper head coming from the greater wing of sphenoid and the lower head coming from lateral surface of lateral pterygoid plate. So both the pterygoids are coming from which pterygoid plate? Lateral pterygoid plate. Medial pterygoid is from the medial surface of lateral pterygoid plate. Lateral pterygoid is coming from the lateral surface of lateral pterygoid plate. Okay. And medial pterygoid attaching to the inner surface of the ramus of the mandible, I told you, whereas the lateral pterygoid extending or attaching to the capsule of the temporomandibular joint, to the articular disc of temporomandibular joint, and to the pterygoid fovea of the mandible. Fine. Now, let us look into the actions. So, temporalis coming from above will elevate the mandible. The posterior fibers of the temporalis will pull it back, retract the mandible. The masseter is a powerful elevator of the jaw. Okay. The medial pterygoid and lateral pterygoid, when they contract simultaneously, they will protract the mandible. Protract it, pull it forward. Whereas alternate contraction will cause side-to-side chewing movements. Side-to-side chewing movements. Okay. Coming to the nerve supply of these muscles, come on. Yes, all of them are going to be innervated by anterior division of mandibular nerve, except A, B, C, D. Can you tell me which one of these is not innervated by anterior division of mandibular nerve? Yes, the medial pterygoid. The medial pterygoid is innervated by branch coming from the trunk of mandibular nerve. Okay. And this nerve to medial pterygoid, it passes through the aortic ganglia without any synapse and goes to supply the tensas, tensa veli palatini and tensa tympani. Okay, the nerve to medial pterygoid. And we have seen that, yes, the temporalis will elevate, the masseter will elevate, the medial pterygoid also will elevate. Okay. The lateral pterygoid, which is inserting into the capsule and the articular disc of the temporomandibular joint directly, can depress the mandible and help you to open the mouth. Okay, open the mouth. Lateral pterygoid. Do you know any other muscles that can help you open the mouth? The suprahyoid muscles. So what are they? The digastrix, the geniohyoid, the mylohyoid, right? They will also help to depress the mandible along with the lateral pterygoid to open the mouth, right? So please make a note of it. It is important. This is a very, very, very high yield topic which you're definitely going to get a question on. Okay. So this is just for your understanding. This is the lateral pterygoid plate. Okay. This will be the medial pterygoid plate. You can see that the lateral pterygoid muscle, it originates from the lateral surface of lateral pterygoid plate. And this is the medial pterygoid muscle originating from the medial surface of lateral pterygoid plate. So when you open your mouth wide, suddenly you might not be able to put it back, close it, okay? This is due to spasm of the lateral pterygoid muscle, okay? You can see that the head of the mandible is dislocated anteriorly, forward dislocation of the mandible because of the pull or spasm of the lateral pterygoid muscle. Hope this session was useful for you. We have taught you all the concepts in the high yield topic. So whatever way the question is put, whether it's an MCQ or essay, short note, or case-based scenario, image-based questions, definitely you should get it right. Thank you. Happy learning.